Everyone just make yourself comfortable. Whoops. We're going to try and make this kind of as informal and informative as possible. That's the plan. We're going to be here between 45 to 60 minutes. So whether we're super efficient and we get all the information out in 45 minutes, we'll let you guys go. But if there's questions, we are willing to take some questions on the chat, and we'll be here till 8 o'clock if there are extra questions. But essentially, I wanted to get this information to as many people as possible, hence the reason why I've made this for free. And I'll give a little bit of background. First of all, if you're new to my world, you've come through Adele's world. I'm Kate Moryoussef. I'm the host of the ADHD Women's Wellbeing podcast. I'm also a lifestyle wellbeing coach for ADHD women, host lots of workshops. I've obviously got the podcast where I interview amazing experts and specialists, trying to find the most up-to-date information for you regarding neurodivergence, especially in women. And I have worked with Adele quite a few times now. She's come in, she's been a part of my ADHD hormone series. So we did touch on progesterone then. She's come in, I think she's been on the podcast. We've done something else for my membership. She's always there and always so happy to help. And I'm so grateful for her knowledge, because not only is she amazing for this community, the reason why this has come about is because she very kindly gave me lots of advice when I was navigating a bit of a tricky time with my own progesterone for my HRT. And I kind of thought, well, if I don't know this and I'm really embedded in ADHD well-being and hormones, and I thought I knew quite a bit, about this, there's going to be a lot of people that will also want to know more about progesterone, because if you've been kind of learning about ADHD and hormones, you'll probably know that estrogen is probably sort of the more dominant player. Like, we hear about estrogen a lot, that interplays with our dopamine. And so very often we have in our fluctuations, and I'm sure Adele will say this much more professionally, but when we have the fluctuations of our hormones in different parts of our life, such as puberty, pregnancy, and perimenopause and post-pregnancy, we notice when the estrogen drops off, like our executive functioning goes down, our mood goes down, our cognition, our word finding, just so many things. But progesterone is just as important, but in a different way. And I think many of us have suffered what I used to call a progesterone sensitivity. And we'll uncover all of this, but I feel like progesterone probably had a bit of a bad reputation amongst our community, thinking that we progesterone and us just don't get along. And probably that has been the case in many, many different circumstances, especially as we know that PMDD and PMS is a lot more frequent in neurodivergent women. There's a statistic that says something, I think it's about 60% of neurodivergent women have experienced PMS, PMDD, similarly with postnatal depression. So we're understanding there's a connection there. And the reason why I wanted to have this conversation with Adele, with all of you here, is because I had really struggled with progesterone with regards to the pill and with the Mirena coil. It really, really didn't kind of work for me at all. I had a quite severe reaction to it. And I was terrified by it. I was terrified the way I turned into a completely different person while I was on the pill back many, many years ago. And when I had the Mirena coil fitted, I think about 10 years ago, and I was told by my GP at the time, there's such a small dose of progesterone, you're not going to react. There's absolutely no way you're going to react to it. And I was terrified because I still had what I would consider probably some PTSD of how I felt on the pill. But I trusted what the GP said. Obviously, I didn't know I was ADHD. I didn't know I was neurodivergent. So I trusted it, and I had the Mirena fitted. And probably within about a week, I noticed a huge difference in my mood, in my behavior, my reactivity, my sensitivity, like everything. My ADHD was just off the scale. to the point where I called up my GP and I begged her. I said, you need to take this out of me. It's like an alien that has taken over me. And if you don't take this out, something bad's going to happen. I was aggressive. I was crying. It was awful. It was really, really awful. And thankfully she listened, and she said, I've never really heard about this before. You've definitely got an extreme sensitivity to this, but most people kind of react quite well. So that was that. And ever since then, that was 10 years, I've been terrified about progesterone. Fast forward about 2 years ago, I then went on HRT, and I was, again, this kind of like fear, this trauma came up about progesterone and how am I going to react, because I was told that if you're having the estrogen, the progesterone has to follow, because we need it to keep the lining of your uterus safe. It's a safety protocol, and you can't have the estrogen without the progesterone. And hence all of this kind of unfolding, that I had to go down a very tailored, patient-specific route with the progesterone, that I ended up taking a very specific type called cyclogest that's normally used for IVF, inserted vaginally. It was very, very, I would say, kind of personalised to me, and we did it very, very slowly with my doctor. And thankfully, things have moved on, and things have settled, and I'm totally okay with the progesterone. I feel it when I'm taking it. It's the 15th day of my cycle and I have to start taking the progesterone. I definitely feel different. I feel probably a bit heavier emotionally. I feel more exhausted. I feel a bit calmer, but in a lower mood kind of way. It's very nuanced, and we can discuss all of this with Adele, but I just think it's really important that anyone that has experienced this, or is considering HRT, or has still got the Mirena or the pill using contraception, and that we have this awareness that we can make more informed choices, and we're able to help if we've got daughters as well, anyone that we're working with perhaps is neurodivergent, we can help them navigate this and understand progesterone, the good and the not so good, and how we can weave this into our lives and understand what the different types of progesterone are. So with all that, I'm absolutely delighted to introduce Adele Wimsett. She is an amazing women's health expert, hormone expert, ADHD expert. She blends it all together and guides neurodivergent women to, I guess, thrive and live better alongside their hormones, understand their hormones, and embrace the hormones and accept where we are in our life, in our different kind of in the different stages where we are with our hormones. So Adele, welcome, lovely to have you.
Amazing. Hi everybody.
Adele, just maybe come in, do a little bit of an intro about how you work, and I guess your special interest as well, and why you think understanding progesterone alongside ADHD is so important for us.
Oh my gosh, this is such a big topic that I could probably talk about for so long. So please keep me on track, Kate. If I start going off and want to get really nerdy and geeky about some of these things, please just pull me back in line so that I don't end up boring everybody with far too much nerdy information. But I'm a women's health practitioner, as Kate said. My specialism within that is hormones and ADHD, because when I was diagnosed, I was horrified at the lack of information there was around hormones affecting traits. Because as I know in my work, hormones have a massive impact on mood. Our brain is covered in estrogen and progesterone receptors. So to me, it was crazy that there wasn't this standard practice of looking at hormones when looking at ADHD, because the hormones play such a huge role in sensitizing neurotransmitters. So if the hormones aren't in the correct levels, and more importantly, the correct ratios with each other, which simply doesn't get discussed, how on earth are our neurotransmitters going to be working optimally? And our hormones do this dance throughout the month, and we won't go into that in here. We've spoken about the different roles of estrogen and progesterone, but today's about progesterone. But there's this dance that happens throughout the month where, depending on your estrogen levels and depending on your progesterone, is going to affect how your traits show up. Now, when we then start weaving in things like HRT, we unfortunately are in a place where we are having to advocate for ourselves because the lack of understanding, largely due to research, which can, by the way, take 20 years to filter down to frontline practice, simply isn't there. So we are having to get this information for ourselves so that we can go in and advocate. And one of the things that I see a lot in my clinic, anecdotally, because like I say, the research isn't there, is the impact on progestins, synthetic progestins, as opposed to body identical progesterones. And as a result of this, which we will unpick lots of reasons why that is, women are really misinformed and therefore are not, in my opinion, making truly informed consent about what they're putting in their body. So, you know, as an overarching statement from me, the biggest thing I want you to leave with is that synthetic progestins are not the same as progesterones. And as a neurodivergent woman, they're likely to have very different effects on you. Okay, but nothing I share tonight, I have to put the disclaimer out there, is an alternative to any medical advice. I'm not suggesting anything that I share with you, you sort of go off and start playing with it. Hormones are really powerful biochemicals, and we really need to make sure that we're taking a really tailored approach when we're considering this and managing our neurodiversity. But it's something I'm very passionate about, that we change this narrative that is fed to women that progestins are replacing their progesterones, because it's simply not true.
Can I ask, Adele, so for anyone that's listening that really doesn't even know about the difference,
yeah,
if I'm saying I was on the Mirena and the contraceptive pill, is that a progestin?
it's a synthetic progestin. It is not progesterone.
Okay.
And would it be helpful to kind of unpick that a little bit?
Yeah.
So progesterone is a hormone that is produced in the second half of your cycle. So you have a rise in ovulation when you are in your fertile years, and you're regularly ovulating. And if that rise is enough for you to ovulate, and only if you've ovulated, you will produce progesterone in the second half of your cycle. If you have not ovulated, you will not produce progesterone. Okay. So sometimes women feel like they have really extreme PMT symptoms and PMDD, for example, because of PMT, but it might actually be something more like something called estrogen dominance that we'll talk about more later. So progesterone, body identical progesterone, like we see in some HRTs like Utrogestin, like the cyclogest that you spoke about, is exactly the same chemical that your body produces, okay? And that will only be produced in sufficient amounts if you are ovulating, all right? So it's the first hormone that we see decline in the early stages of perimenopause. Progestins are a synthetic version that were produced decades ago by pharmaceutical companies who couldn't patent a natural hormone. So they changed the chemical structure of this molecule to the only similarities they have with progesterone is preventing the pregnancy by blocking the cervix, providing like a thickening in a cervical mucus to prevent pregnancy, and to stop the thickening of the uterine wall. That is it. There are no other similarities. And yet the progestins have a significant number of risk factors and side effects that, in my opinion and experience, do not get properly articulated to women, as opposed to the progesterone. Now, if you are a woman who takes body identical progesterone and is having a horrific effect to it, when you hear somebody say, progesterone is so supportive, it does these incredible things to the body, which we can talk about, this feels really frustrating. And this is where it gets really quite niche for the ADHD community, because many ADHD women do not have this experience with progesterone. And I want to, as we go later into this, we're going to really unpick some of those reasons why. But that is the difference between them. They're different molecules, they've got different purposes, and they are doing different things in the body. Does that help to explain that?
Yes, very much so. And I think we're hearing from women that are saying that, that you're seeing even the body identical Utrogestin and the cyclogest have given you the feeling of PMDD.
Absolutely.
So And I think that's really validating to hear that, okay, so yes, you can understand from a synthetic perspective, it's, you know, we're going to feel this sort of like more depressive, low mood. But actually, even with the bioidentical, and is that because from an ADHD neurodivergent perspective, it's almost our own progesterone's attacking us. Like, even though it's the natural progesterone, it feels so extreme to us. Like, we have this propensity to feel like we have this sensitivity to our own progesterone.
So the short answer is we simply don't know. Okay, like so much of the research for us, basically everything we know about ADHD is based on naughty little boys, right? We don't have the depth of knowledge that we need for the female physiology. The way we respond to medication is different because of our hormones. You know, the whole female experience is largely missing from our understanding of ADHD. We're just at this point where they're even starting to consider the impact of hormones. So the reason as to why women have this, we don't know. But there are lots of reasons that it can be. So I'm really happy to start to go into that if that's useful, or people feel there's been enough context provided around progesterone and progestins. But there are a number of different reasons why women can react.
Yeah.
And that's very real. It's a very real experience. So quite often women are gaslit. They have this reaction to it and can feel quite traumatized by being told, oh, there's no link, or it's local, or it won't be doing X, Y, and Z. And actually it's having a huge impact on mental health.
Yeah, I think it's really important that we hear that from you, because you're seeing so many different women. And I also just I've got this book, ADHD Girls to Women. It's by Dr. Lotte Borg Skoglund, and she was on my podcast, and she is I think she's Swedish, psychiatrist, also a hormone expert. And in her book, I just wanted to read this one small snippet. It says, estrogen appears to have a protective effect for women's overall mental health throughout life. In contrast, on a theoretical level, PMS and PMDD symptoms are thought to be linked to rising levels of progesterone during the luteal phase. And there are some indications that progesterone, or metabolites of progesterone, may have detrimental effect on some women and their ability to handle anxiety and feelings of aggression. Thus, progesterone has the potential to worsen ADHD control and everyday functioning. I just found that really validating, and I wanted to read that out to people. So we know from a psychiatrist, and Dr. Lotte is incredibly knowledgeable in this field. And so the fact that she is putting this in a book, we now know that we're not imagining things, that there is a link between the progesterone and our probably, you know, decades-long PMS and PMDD, and maybe postnatal depression for many of us as well. What are your thoughts on that?
Oh, so many. Okay, so I'm going to try really not overcomplicate this. So what happens with progesterone in the body is really important here. Okay, so one of the doctors that I trained with is a doctor called Dr. Phyllis Bronson, who is an international lead on progesterone and body identical hormones to support mood and emotion. I can pop the name of her book actually in here, which is amazing. And she is one of the doctors who has done some incredible work in this field, and have been, I mean, they've looked at things like treating bipolar and schizophrenia with progesterone. It's really been quite incredible. But this information is not out there in the mainstream. And one of the issues with one of the things that progesterone does that is not spoken about enough is that it sensitizes estrogen receptors. Okay. So just bear that in mind as I explain this. So Dr. Bronson's work is saying that the problem with our current approach to using progesterone is that we are massively under-prescribing it. It's in very low doses. So what happens, I'm talking just from an HRT perspective here, I'll come back to the PMDD and PMT link, but I think it's important probably to say this at this point, is what happens is our current go slow, titrate in, gently up approach is actually more harmful when looking at mood conditions for women. And actually her clinical trials have started on a minimum dose of 300 milligrams, and Dr. Catherine Dalton's starts at a minimum of 400 milligrams. Now, this is usually transdermally. We're seeing for mood and trait management that actually transdermal progesterone is much more effective than oral and vaginal. And I'll come back to why, which is to do with the detoxification pathways. But for now, what we are seeing in long-term clinical trials for some of these doctors doing this work is that much higher dosage of progesterone is what's overcoming these symptoms that women experience when they start taking it. And it's this go slow and steady, titrate up gently approach that is causing it. And the reason for that is that what the progesterone is doing is it's coming in and it's making the estrogen receptors massively sensitized. And this is what is causing some of the symptoms. And what their clinical trials are showing is that actually going fast to much higher doses of progesterone is what's counterbalancing it. So I think this is some really interesting work to have a look at actually over time with where we're going. And this gets even more important. And this is something that I'm passionate about in my clinic, is really understanding what your unique body is doing with hormones. Okay. So we can look at the detoxification pathways in the liver of how your body breaks these down. And I call them like hormone gremlins. If your body has we have these lovely estrogen and progesterone molecules that are doing their thing, but the body can't get rid of them in their whole form. So what it does is it comes up to the liver to be broken down, where there are several tunnels that it can go down. And depending on your liver, based on genetics and based on lifestyle factors, the tunnel with the biggest opening is where it will chuck the hormones down. Now, if it's not our favorable tunnels, it turns it into these hormone gremlins, where the metabolites, the breakdown of these hormones, the compounds that get broken into, cause massive problems. Okay, so it's not the estrogen and progesterone, but what your body is converting it into that becomes the problem. And this is where we see risk factors coming in. So if your body chooses a pathway to convert estrogen into these gremlins, and it's these gremlins that are attaching into your estrogen receptors, and then your lovely progesterone comes in and makes that work better, you're going to see your mood go all over the place, right? And that's not actually the progesterone's fault, but it is indirectly the progesterone causing it. Does that make sense? It's a really complex process.
Yes.
That I hope I'm sort of explaining. So it's not as simple as saying, I have a progesterone reaction. And some women do, okay? But it's much rarer than we would sort of believe, because it's becoming something that's spoken about more. And this is where it becomes really important to work with a practitioner who really knows what they're doing. I can't encourage you enough to work with a prescriber who's at least willing to understand neurodiversity and the importance of getting HRT right, because of the added risk and experience on our mood, you know. Does that help? Sorry.
Yeah. No, first of all, it's absolutely fascinating. And what's just made me laugh, but not in a funny way, is that so I've been upped my progesterone from 100 milligrams daily for 14 days to now 200 milligrams. Now, I forgot that I did that. And for the past 5 days, I've just been taking 100 milligrams and I felt dreadful, like brain fog, exhaustion. And I was thinking, what's wrong with me? Like, I felt like, have I got COVID? Is it, I really not felt myself.
What we do.
Yeah. And I've just looked, and you just said that, and it says take 2. And so I think that obviously my progesterone levels are too low, which has made me feel even worse than I did before I started taking them. So that just shows that's my ADHD, just not checking, not reading, forgetting that I'd been upped. I'd gone through a whole hoo-ha. I had to go and have investigative surgery to do with my progesterone levels and all things like that. Hence the reason why we were speaking, Adele. And that's after that, he said, right, we need to get your womb lining thinner. So let's up your progesterone. But this is fascinating because we're scared of the progesterone. But what you're saying is actually we need to be more extreme to kind of almost like break that barrier and feel the positive effects of the progesterone.
Oh my goodness. I mean, this one particular doctor who's undertaken some research on bipolar and schizophrenia, they are using up to 2,500 milligrams. That would be 25 of those Utrogestin capsules. Now they're using this transdermally, it's not in capsule form, and they're seeing really good results. And I just want to explain a bit about why it's so important that as a neurodivergent woman, you get the right vehicle to deliver your hormones to you. Okay, because the way in which the hormones enter the body has a big impact on these metabolites that I've been talking about, how the body breaks it down. Now, when we take something orally, which is actually a really effective way to take progesterone for lots of neurotypical women, some neurodivergent women, there's no magic formula to this. So just because I'm saying these things happen doesn't mean it's going to be your experience. But when it's taken orally, it goes very quickly through a detoxification process. So quite quickly, it's broken down into these metabolites, one of which is something called allopregnanolone. You don't need to remember that, but this is the one that gets associated with PMDD. And this is because what progesterone should do, it should be like Valium for the nervous system. Okay, that's what it should do. And that is incredibly frustrating to hear when that does the opposite to your nervous system. But that is what it should do. Actually, a woman's nervous system cannot function optimally without progesterone. Okay, that's why we get this inner scratchy feeling where everything feels just difficult. Like I could say I'm taking you away on the most magnificent trip, and it would just be like, oh my gosh, there's so much to do. This is just I should be enjoying this, and I feel guilty that I'm not. This is progesterone deficiency. And when progesterone is working properly, it sensitizes a neurotransmitter called GABA in the brain, which makes everything go, oh, okay, those external stresses haven't changed, but I can deal with it. It's like, okay, I've got this. Now, when we're looking at things like PMDD, which we know ADHD women are 10 times more likely to experience, we genuinely do have worse PMT than neurotypicals. We're not being hypochondriacs. It's not normal. It tends to be more extreme. The progesterone gets broken down. This allopregnanolone doesn't work properly with the GABA. And sometimes we see this with progestins. So when women have had this sensitivity to progestins, often I'll hear in clinic women say, I went crazy on the pill. I cannot have the pill. I don't feel right on the pill. This is because we think, again, not the research to support it, because drug companies tend to fund research, and there's not much joy to be made if they start looking at all the things that these progestins do to a woman's brain. But it's thought that the progestin locks into the receptors, so this calming GABA can't do its job, and that potentially this causes long-term damage to the receptor, so that when we then try and introduce a body identical progesterone, it can't quite do what we want it to do. So it almost causes this progesterone sensitivity, which then flares up as mood imbalance. I'm trying to simplify that. Does that make sense, or have I just confused?
No, I mean, there's so many questions going on. There's a lot of validation.
Good.
Yes,
Good.
it's being recorded. Don't worry. Okay, so there's one question here that I thought was, let me see if I can find it. Okay. So someone said here, very validating. Weirdly, I am fine with the progesterone only pill and have been for years, but the 10 days on 100 Utrogestan are awful. Marginally better than vaginally than orally, but still very depressed. Very interesting to hear. And higher doses and the transdermal. Now, people are asking, how can we get hold of transdermal? Because it's not offered on the NHS, is it, in the UK?
No, this is what is so frustrating, because everything that I have seen around how supportive body identical progesterone can be for mood, which is great for us, right, is transdermally, and it's not available unless you get it through private. We've got a private clinic, we can provide it, but it comes with a cost, and that's just so frustrating, because often as ADHD women, we spent a fortune going through assessments and possibly looking at medication, and then it's like, well, now I've got to pay this to kind of just get my hormones sorted, because this is the physiology and the specific needs that I have. But unfortunately, that is where we are at the moment in our country. I
remember having the conversation quite a few years ago now, maybe it was with you or someone else. I mean, you know, we've been slogging at this for a while, and that this transdermal was very sort of, oh no, we don't really talk about that. And now, are we hearing that maybe doctors, you know, practitioners who are working maybe the NHS and private clinics are starting to become more open to using transdermal, because I felt like maybe a few years ago it was still a bit kind of like not in the mainstream at all.
It's not in the mainstream.
Okay.
That would be I mean, I'm struggling still with doctors telling women that progestins are progesterones.
Yeah.
You know, I've got women that I really advocate to go back to GP and say, I only want body identical progesterone, and they're coming out with a combi patch. A combi patch is going to be a synthetic progestin. You know, it'll be a body identical estrogen, but it's not a body identical progesterone. So we are so far away from women's mood being managed effectively through hormones. And actually there is so much that can be done, but unfortunately where it is at the moment, it comes with a price.
Yeah, and we've got a question saying, if we're finally done with perimenopause, should we continue with estrogen and progesterone both?
So there's no time frame to come off of HRT. You know, we've definitely moved away from this, oh, you need to be coming off it now. And Dr. Rosensweet, one of the most incredible doctors in the States, who actually trains doctors in his menopause method, he put his mum onto HRT in her 80s. You know, so actually, if you're feeling the benefit from it, we know the long-term protective benefits. You know, even things like progesterone, it blows my mind that women who've had a hysterectomy are not offered progesterone, you know, because there's this medical mindset that it's just to protect your womb. It's like, that's so factually incorrect. You know, it protects your breast health. It actually creates more bone formation. It protects your nervous system. It's been shown to support with MS. It does all these amazing things to protect the body. And we're denying women with a hysterectomy access to that. That's crazy.
Yeah, and I mean, let's talk a little bit about that, because I remember when we did a workshop a few years ago, and I loved your analogy. You said that estrogen is kind of like the party, like if you're going to take a drug, it's like the party drug, and then the progesterone is kind of like the come down, the calmer, you know, I'm not going to start naming drugs, but but I felt like it was a really good analogy to be able to understand, actually we demonized a little bit, maybe in our own heads, due to ignorance and due to misinformation and lack of education from doctors, that we've demonized the progesterone to just be a depressant. Actually, when it's done right, and when I've taken the right dose of my progesterone last month, I sleep like a baby.
Yeah.
I'm calm. I'm a more relaxed version of me. I may be a bit kind of not as excitable, I would say, not the enthusiastic version of me, but
yeah,
definitely sleeping better, and I'm feeling calmer in my nervous system. Can you tell us a little bit about the good stuff? If progesterone is working well for us, what should we hope to feel?
Oh my gosh, when progesterone is your friend, she is like literally my favorite hormone ever. When she's working for you, she just takes you to this place of, the way to describe it is like, yeah, I'm all right. You know, I feel like I'm good. I'm sleeping really well. I'm getting good restorative sleep. And I'm not, my head's not spinning off everything, the overwhelm goes. You know, that's the biggest thing that women notice. They're like, yeah, I'm feeling better. I just feel better. She just comes in and soothes you. And whilst the research on this is really all over the place, I'm yet to meet a woman in clinic an ADHD woman in clinic who has beautiful adrenals that aren't either too high or too low. Okay. And our adrenals, cortisol is the queen bee of the hormones. Okay. The body will prioritize cortisol. Now, if we make an assumption that most ADHD women have an imbalance with cortisol, what the body will do, and this is it's much more complex than this, but for the sake of this, it will steal progesterone to make cortisol, okay, because the body's prioritizing this. So if our adrenals are out, most women in the Western world have some level of progesterone deficiency. We are the most educated generation of women that ever existed. We were sold this lie that we could have it all and it would have no impact on our health. You know, we can be the mums, we can have the career, we can have the education, we can do it all and it would have absolutely no impact on us. And here we are, a generation of burnt out perimenopausal women struggling to like piece it all back together. And I would say that a big part of this is progesterone deficiency, that we have gone and gone and gone. And we reach perimenopause where we're not ovulating as frequently and therefore not producing the progesterone And our cortisol, where our adrenals should be taking over our estrogen and progesterone production, they're barely staying on top of their cortisol production. And they're still like, forget it, I'm not taking this over for you because I haven't got the capacity. So we see these massive symptoms, and you add in ADHD traits into that mix. It's complex to go, well, what is this? You know, am I going crazy? Is it my ADHD? Is it the hormones? And that's my job. It's like, let's sort your hormones out. Let's see where you are. And then you know what you're left with.
Yeah. So are we, you know, when we do get blood tests, if we go to the GP here in England, I've been doing this on the NHS, they say, right, well, do your bloods. If you kind of say, I think I might be perimenopausal. And as we know in the know that the bloods don't actually, you know, often reflect what's going on. We could be feeling horrendous, but our hormone levels are kind of like in a safe space where doctors wouldn't consider that we need any sort of intervention. Whereas we kind of go to more functional doctors, more, you know, specialists like yourself, and we know to look at how we're feeling and really kind of like look under the bonnet, so to speak. And so would you say that when we get the blood test results from the progesterone, is that typically tell us what's going on, or is it still our feeling and how we're sleeping? And
okay, so the thing I am primarily concerned with is, how do you feel? What are your symptoms? How are your traits being affected at different times of your cycle? And are you ovulating? That is going to tell me far much more about your hormone production than your period, although that is our fifth vital sign in terms of communicating how well we are. It doesn't mean there's anything wrong with your reproductive organs if there's something that isn't what we want. Now, blood tests are incredibly, there's nothing more accurate than what is happening in that second of that moment that you had your blood test, right? So your hormones are pulsing. So the point at which you had that pulse, there could have been a higher reading. And particularly in perimenopause, sometimes estrogen is the party girl. She is out there having a party all by herself. She could be ragingly high up here one day and then crashingly low. So you get symptoms of both too much and too little. So a blood test to me isn't helpful in that way. What it is helpful at doing, when you're actually asked to have it on specific days of your cycle, and again, this is not something I see as standard, between days 19 to 21 of your cycle, I'm interested in looking at what your ratios of estrogen to progesterone are. Okay, that's really helpful to me to put in the context of your symptoms. But in terms of the things we're talking about here, a blood test isn't very helpful. I would actually suggest, and this is something I use a lot in clinic, and I'm happy to share the details when this goes out if you want, is a device called a mirror. And this is as accurate as a blood test, but it's a device you have at home. You pee on a stick, you pop it in the device, and within 20 minutes, it tracks on your phone your exact estrogen and progesterone levels throughout the month. And what I can do is interpret that data and say, we have an issue with estrogen dominance, or you are not ovulating and you are not producing progesterone. And we can look at that in the context of your traits and say, look, your traits are really flaring up here when X is happening. So it's very validating, it's very accurate, and you don't have to have the trauma of having to go to a doctor's and go through that process, which a lot of women I see in my clinic, they're like, please don't even make me phone a doctor. The thought of having to do that is just too much. So this is a really empowering way to get incredible data, and it's much more affordable than a Dutch test. Yeah. So, which is another test. So there's ways that we can work to get this amazing data to see what's going on for you within the context of your hormones.
Okay, yeah, we've got someone saying they use the mirror lever. Would you recommend? That's really good Absolutely. To know. Yeah, I mean, we've got someone saying, where does testosterone come into all of this? I don't want to confuse people, but maybe just it's a little kind of snippet sideline into testosterone.
Do you know what? So what I'm going to, because of the context of this webinar being specifically about progesterone and progestin, I'm going to make it relevant to that. Okay, so what we need to remember is all our hormones have to be in the right ratios to each other. Testosterone, we produce more testosterone than we produce estrogen. And it's really important for our neurotransmitters. It plays a role with dopamine. Now, what progestins do, like the pill, the depot injection, the Mirena, whatever it is, when we have the progestins in the body, they increase a protein called SHBG. The role of SHBG is to bind with testosterone and estrogen in the blood, and it renders it inactive. So high progestins from using some kind of synthetic progesterone, this raises the SHBG, which then creates symptoms of hormone deficiency like testosterone. What does this do? One of the symptoms of this, cognitive function, forgetfulness, unable brain fog, all the things that we see with ADHD. And we think, is that a trait or is that this? Yeah, it's not discussed in a GP's room, you know? So actually, this is something that's really important. If you're noticing these kind of symptoms, and it might, and then you could have a blood test that says, oh, your testosterone's fine. And it's like, well, why am I getting all these symptoms of testosterone deficiency? And it's because of the progestin. It's preventing sufficient testosterone being bioavailable to the body. So therefore, you'll get symptoms of deficiency.
Okay. Wow. I mean, this is like, this is why this was so important. Okay. There was I read just before, I love the resourcefulness and innovation going on in the chat, that somebody and a couple of you are cracking open the Progesterone and rubbing onto their arms. Does that work?
So it's really difficult because there's not sufficient research on transdermal progesterone to protect the endometrial wall. Okay, that's first of all. So this is one of the reasons that the British Menopause Society would say that they don't necessarily advocate for transdermal progesterone at the moment, because the research isn't there to protect it. However, doctors like Dr. Rosensweet, who have used it clinically for years and years and years and years, do scans on women of their uterus to make sure it's not thickening, and shows that it's very effective to take it transdermally. The problem is when you're just taking a capsule and using it this way, is we don't know whether the other ingredients that it's mixed with is sort of helping it to travel through, and we don't know if that's being properly absorbed. Okay. So we don't know, and it's not something that I would be able to suggest that you do, because we simply don't have the data about it.
Yeah. Okay.
I just saw something about PCOS. Yes. Can I just speak to that? Because I think it's really important that when we're talking about HRT, that we're not thinking of old ladies, right? I think we've moved forward from that, but actually where it is absolutely not discussed enough, definitely wouldn't be considered in NHS practices, is PCOS and progesterone, because just by nature of PCOS, many women will be progesterone deficient because they're not ovulating regularly. We know there is a link with PCOS and ADHD. We've got one teeny tiny piece of research to support that, but I definitely see that link in clinic. And we're progesterone deficient, and actually having a bit of progesterone on those months you've not ovulated can be a game changer for regulating mood, supporting sleep, increasing energy levels. So yes, it can be used for that. Progesterone only HRT can be really supportive for PCOS.
That's really interesting. So we've got a GP here. I had a feeling
amazing.
At least one or two doctors here.
Yeah.
So GP who happen to also have ADHD, a bit pairing, thinking about HRT options. She's saying it's very interesting from a personal professional perspective, because she can look after ND women in the practice.
Yeah.
Yes, we'll get some studies to you, but also she says, wondering how we navigate this for women who require a synthetic progestin for contraception and also HRT due to their age.
How do we navigate this for women who require? I think my initial question is, why is it they require a synthetic progestin? Is that purely if they're asking for contraception? Okay, this is, whilst I'm sharing here the impact that I see clinically in terms of importance of knowing the difference between progestins and progesterones, making a decision about any hormone, whether it's body identical or synthetic, is not an easy decision for any woman to have to make, and certainly not for a prescriber, because there are no easy quick win options, and quite often, frankly, it's a male privilege to not even have to think about this stuff, right? So that's my overarching thing for this. There is no right or wrong answer, and unfortunately, if a woman, it's all about what is her priority. And if her priority is, I need to have a contraceptive, there's no choice but to have a synthetic progestin, because that's her priority and that's need. And progestins have been flipping amazing at making sure we have control over how many babies we have, and, giving us so much freedom. Let's not lose sight of that. I just feel we need to have much more informed decision making so that women can really consent to what is happening. And that still may be the best choice for them. Many women can actually get really positive benefits from being on the Marina, because things have been so erratic and so extreme and symptoms so difficult, that having that flat line of hormones that the contraceptives allow is like a godsend. It won't improve mood, but it will balance things out, you know, flatline things when it's there. So I think there's no easy answer other than what is the priority for that woman? Does she really understand the side effects and the risks associated with it, and that's still her choice? Then, you know, that could be the best option for her. So I don't know if that helps, but I think that's just the reality for women.
Yeah, and we're getting some questions about ADHD medication
Yeah.
and understanding how to, I guess, you know, work with our hormones alongside and maybe the HRT, progesterone, alongside the medication that we're taking. What are you seeing in your clinic, and maybe have you got any advice for people who want to kind of really work with both?
So where we do have a study, I think it was June 2023. I mean, look how new this research is. That we know hormones affect the effectiveness of ADHD medications. Estrogen sensitizes it, progesterone dampens the effect for some women. So we think our medication has stopped working, which it kind of has really, because again, medication was developed around a male physiology, not women who have this dance each month. So what we know to be true is, yes, it will affect it. So obviously, if you start adding in oral progesterone, then you've got to take into consideration that that could have an impact on your ADHD medication. At the moment, we're guinea pigging what to do about that.
Yeah.
So that's what I would probably say on that. Does that help? I think
Yeah.
the best thing to do is track.
Yeah, and I think if you've got a really good psychiatrist, hopefully who is informed, and there's an episode, I don't know when it was, with Dr. Helen Reed, and she's a psychiatrist who said that when she has her female patients come in, she gives them extra medication and maybe adds some anti-anxiety medication towards the end of their cycle. So they come up with like a way of dancing around the hormones alongside the medication and understanding their hormones. And I just thought that was really progressive as well, coming from a woman. She had ADHD herself, and she recognized the impact that the medication wasn't working as well towards the end of their cycle. So it just, that validates it, doesn't it? That we know that as progesterone rises, maybe, and our ADHD symptoms become worse towards, you know, our period. It's all kind of awareness, isn't it? And information. And just to go back to people are saying, like, how can I, you know, wherever people are living now, and I think there's quite a few people from all different places, different countries, and they, you know, they want to speak to someone who's as educated and as informed as you, but they're going via their own doctor or a psychiatrist who just isn't informed about hormones. Like, where do we turn? It feels like it's very few and far between this information.
Oh, I mean, I wish I had a big pool of resources and professionals in different places to send to you, but there really isn't. I mean, I'm really happy for you to always reach out to me and ask me any questions. I mean, I offer discovery calls. I work with women all over the world. But in terms of there being like a central organization or somewhere to support with this, it's not there. You know, people are starting to, the thing that is great, and I would say massively, I've seen over the last few months, is more accounts on social media of where practitioners are starting to talk about this link. I'm sure you've seen that too, Kate. And that is really reassuring to me. Like, okay, this stuff is filtering down. Because there's no standardized training, there isn't really sufficient research. I think there will be over coming years. So it's difficult to deliver that training, particularly in a medical environment where no one's leading on this. So as it stands, I think probably your resources, Kate, are the best central place to kind of come to, really, for knowing who to talk to. And that's a really sad state of reflection of where we currently are with this.
That's why when I did the ADHD hormone series, that was 2 years ago, and I really worked so hard to try and grab whoever I could that had up-to-date information, with you included, so more women can advocate for themselves. And I was thinking, actually, you know, from your perspective, it would be amazing for women to be able to download like a one-page PDF where we can almost like download it, and we give it to our GP and say, I'm fully aware that you have so much on your plate and it's really hard for you to know about neurodivergent women's hormones and the impact that might have on HRT and birth control. But if we could hand that to our doctor or our psychiatrist and say, even if you can't do any of the research, here's some, here's someone that does know. Because we have to, and unfortunately, we're in a position now as women with ADHD, we have to advocate for ourselves until the tide changes and until this is common knowledge, because I know that we are not, there's a lot of us out there. And there's a lot of women that have suffered with PMS, PMDD, postnatal depression, so many hormone related health conditions that have not been diagnosed with ADHD and or autism. And so we kind of need to advocate for ourselves until the medical professionals catch up. So I would just say, if that's not too much work for you, if you could create
well, funnily enough, Kate, it's in the process of being created.
There you go. You see, yeah, like-minded.
So what we're going to be having is there's going to be a handout for women to have to go, how are my hormones affecting my ADHD traits? So that's going to be available as a download from my website, and also one to be able to take to GPs and to take to practitioners, to be able to do that, share that information with relevant, rightly so, medical practitioners will want to see links to research and want to have that understanding. So we're going to put that all in one place, just so you can kind of go, please read this. Amazing. This is where I am. So it's a work, it is happening.
and what I'm going to say is there's a lot of very knowledgeable people here in the chat, and afterwards you're going to get the recording, and if anyone has any research or something that they want to share, I'm happy to use this the mailing list that I've got from this, and I can send you some bits and pieces, because I think, as we know, it's growing information. We haven't got the research and the evidence, as much research and evidence as that we should. So I know that Adele is very kind, and she will, send whatever's needed as well. So I just want you to know that I will kind of follow up with some links and articles and research. We've got a couple more minutes. I just wanted to ask you a question, because this was something I mentioned to you. So I was prescribed Progesterone, and I thought that was the only, I don't know if everyone can see that, but I thought that was the only one I was going to take. And then my next, my brain's just gone. When I went to pick up my next prescription. Thank you. Then my next prescription, I got prescribed this different brand. And I was really worried because of everything that comes with my progesterone kind of history. I was like, I'm too scared to take this. When women are getting prescribed different progesterones, even if it's not the synthetic and it is the body identical, is there a difference, and do we need to be worried?
Oh, I'm so pleased that you brought this up, Kate. So this is even more important for neurodivergent women. There is not this understanding that these slight shifts in medications can have a significant impact on our traits and our mood. And when we're seeing things like increase in suicidal ideation as a result of some of these changes, it's really serious. And most prescribers aren't even aware that this is what's happening. They're writing a prescription for the Progesterone, the oral progesterone, going off to the pharmacy, and the pharmacy isn't giving the Progesterone, they're giving an alternative. Mm-hmm. And this is really messing women up who have established themselves on the Progesterone. And I'm seeing this in clinic. And what is happening is that medication like that is made from the same hormone, but might have different ingredients, different quality assurance. So the Progesterone, what you want to do is that when you ask for the prescription, is make sure that you request the Progesterone GB for Great Britain, so that when you get the prescription, that's an EU one, and it's different. It's been through different processing. This is as far as we can get to the bottom at the moment of why women are having this reaction. We don't know, but we know that women are reacting to it, but they are being told that it's the same medication, but it's not having the same effect. So this is really important for managing your ADHD moods. For example, I had a woman in clinic this week who's had this exact same thing, and suddenly she's not sleeping again. She said, "What is this? And I said, okay." And so her sleep, that was amazing because of the Progesterone, has now gone out the window, but yet she's told by the pharmacist, well, it's the same medication. And she's saying, it's not, because I'm not having the same reaction. And she's being told, and this is a pattern that I'm seeing.
Gaslighting.
Tough. It's the same. It's the same thing. It's not going to be that. And all the women are going, it is that, and getting really stuck with this place. So a way to overcome it that I've seen, so I love someone's just put believe women. Yes, absolutely. That we need to have it specified on the prescription and not leave the pharmacy until you get the Utrogestan.
Yeah. So just to follow up on that, after Adele's advice on this, I mean, poor Adele just gets all my voice notes all the time.
I love it.
So I went to the pharmacy and I said, I'm not even going to take this one because I'm too terrified. I was prescribed the Utrogestan, and she said, well, it just depends what we get in. And I said, I'm really sorry, but can you swap it for me? And actually she was quite accommodating, saying that she's not done it yet, but I pushed back and I said, I'm really sorry, I'm not willing. It's taken me so long to find a progesterone that works for me. I'm not willing to take that risk. And I did quote, and I said, there's a lot of women who are saying that this is not the same, that they're not reacting. Some women, I looked online, some women were saying they had no change and it was absolutely fine. Some women, I don't know, some women said it was better for them, but this wasn't a neurodivergent study of women. This is just sort of, a big case study. So what I'm trying to say is don't be afraid to speak up, use your voice, advocate for yourself, and ask for what it is. If the Utrogestan's working and you've been prescribed the Geprotix, I don't know how you pronounce it.
I don't know either.
Yeah, and if you don't want it, go back, call your GP and say, no, I need the one that I've been prescribed. Right, we're coming up to the end. I'm going to just literally, is there anything else, Adele, that you think that we need to know that I've not asked you? Could this
like I said, I could deep dive into this and bore you all to tears talking about progesterone and progestin so much, but I really feel like we've covered the core elements. I think the key takeaways for this are progestins are not progesterones. If you've had a negative experience with progestins, it doesn't mean you will with progesterones. But that being said, we want to make sure that there is some oversight and support because of your neurodiversity as to the added complexities taking HRT can have on managing your traits, affecting your medication and your mood. We need to get it right. And that progesterone sensitivity isn't necessarily progesterone sensitivity. There's lots of reasons as to why women can appear to have a reaction to progesterone that might be not the progesterone itself. So it's really important to unpick the uniqueness of why you are experiencing that, because we don't want you to deny yourself these lifelong protective hormones because we think we've got a sensitivity to something. Let's look at the root cause of that reaction so that you can benefit from the protective elements of body identical hormones.
Someone said that they have booked a discovery call already with you, and you need to be in every GP surgery in the UK.
I wish I was.
I totally agree. This information is, I mean, I hope that, for the next generation of women, they know this. This is just sort of, future doctors are learning this information. It shouldn't sort of just be, it shouldn't just be sort of a very niche topic of conversation where it's not found in commonplace, and GPs need to be knowing this. And there are GPs, and I just want to say there's a lovely lady that's just messaged saying she's a GP in Austria and she's still being gaslit by her colleagues. So yeah, it's not great, but we're getting there, and this conversation is really powerful. Someone said, can we save this chat? We're going to save the chat. I'm going to attach it to the recording. I think the amount of information that Adele's given us, I mean, I'm just blown away and totally in awe of, your knowledge and the way you are able to explain it all and remember it all is just incredible. But if anybody needs to watch it again, I totally understand. I think I might have to. And yeah, I think let's leave it here. However, if anybody had sorry, it's my dog now barking. If anyone's now got a question that wasn't asked, I'm happy for you to email it to me. And if Adele is happy to answer it or anything like that, or just get in touch with Adele, tell people how they can find you, please.
Well, I like hanging out on Instagram and having a good old rant about women's hormones and ADHD quite frequently. So you're all very welcome to come and hang out with me there.
Harmonizeu.co.uk.
Yeah, and there you can see how to work with me. I do discovery calls. I offer one-off sessions for women who just want to understand what's going on and to get to the bottom of what's happening, or I offer packages, but I also work with a specialist GP who can do really bespoke, tailored HRT if we need it. I mean, I'll always try and avoid that because of the cost. We'll always look at trying to get that in other routes, but it is there as an option for women. I mean, I like to offer a buffet where we cherry pick all the specific bits that are unique to you to create a plan that works for you. And it is a dance, you know, please. We like quick wins, right? That's our brain. Like, I want to do something, I want it to work immediately, and that's what I want to happen. HRT isn't like that. It, especially when we add in our neurosparkliness, it is this dance, and it can take a while to get it right because we might get this progesterone right, and suddenly this like creates another issue, and we need to like manage that. So it's just to prepare any woman going any route with HRT. It is this dance.
Amazing. Thank you. I've just linked in the chat as well, the hormone series. There's a conversation with Adele on there as well, where we kind of talk about hormones in general. And that's really worth, you know, watching. Lots of other conversations about hormones and the impact with regards to ADHD and how we can kind of navigate that. But I think it's just any help that we can get while we are swimming through these very sort of murky waters until doctors and healthcare professionals catch up, and there's actual proper research and evidence that we can, it's not just the anecdotal stuff, and we should not be gaslit and dismissed and invalidated anymore. Many of us have lived far too long in the dark without the right medication, without the right support, and we're worthy of it. So we just need to keep plugging away. And Adele, you are doing incredible work. Take care, everyone. See you later. Bye.